And now I will ask the five podium presenters to come up. So Ching Lung Huang, Emma Pownell, maybe some of them are virtual. Oh, okay. Some of them are virtual. Some of them are here. Rasai Sala Handish, Eden Dales, and Min Hong Kim, and Gyung. Oh yes. So whoever is here, I'm here, and I guess I will try to figure out by your name tags. So each of you will have 3 minutes, and I guess the first one is here in person. Okay, so Xin Lung Huang is at University of Toronto, and she'll present on a competency-based concussion curriculum for primary care residents, the benefits, challenges, and future directions.
Thank you, Dr. Tajalia, for the introduction. Perfect. So I would like to start off with a brief background. So in 2017, in a study done by Mann et al., they conducted a survey to University of Toronto family medicine residents, and that really highlighted some important knowledge gaps around both the diagnosis as well as management of concussion. And that was done in 2017. So fast forward to our pilot study done in 2021, 2022, we administered a similar survey also to the University of Toronto Family Medicine program. And we found that the knowledge gap has largely persisted despite over the number of years, the increased awareness and education around concussion. For instance, when residents were asked about the appropriate management of concussion, only 32% of the residents were able to answer that question correctly. And when asked about some of the red flags that may predict the potential for prolonged symptoms or the influence on investigation and management of concussion, only 18% of the residents were able to identify the red flags. Therefore, our study aim is to evaluate the short and long-term impact of our curriculum on concussion knowledge of family medicine residents. So for a brief study overview and our findings, our pilot study was conducted in 2 phases. In phase 1, it was conducted at 7 family medicine residency sites at the University of Toronto. And we had a 2-hour workshop that was case-based as well as interactive. We chose a smaller time frame for the workshop, largely because in the 2019 study by Lam et al., they had a 6-hour concussion workshop, and they found that there was no statistically significant increase in the knowledge of their learners. And we analyzed our pre and post workshop survey in order to find out the short-term impact of our study. And we found that there was a statistically significant improvement in knowledge in the learners. Moving on to phase 2, it was conducted at 2 residency sites. And we incorporated 3 half-day concussion clinics for the residents to increase their concussion clinic exposures, as well as to apply some of their knowledge. At the 2 sites, the workshop was also delivered slightly differently, such that site 2 actually had the involvement of 1st and 2nd year residents, in addition to physician teachers. And we assessed the long-term impact at 6 months by looking at survey as well as semi-structured interview. And what we found was that there was a significant increase in confidence in competency of the residents. In conclusion, our curriculum design from the short and long-term impact, we found that it is a valuable tool to help to address the concussion knowledge gap. And we hope for future project sustainability to continue involving 1st and 2nd year family medicine residents. And we would also like to say a big thank you to the following organizations. Thank you.
And I'm going to ask all the speakers to make sure you speak into the microphone because it's not easy to hear you otherwise. So next we have Emma Pownell from Trent University, who's going to talk about assessing eye movement performance and executive functioning after a concussion.
Thank you. Oops. Go back. Here we go. Okay, so as we know, concussions follow a period of disruption to normal function. Individuals with prolonged post-concussion syndrome or symptoms, they experience a range of difficulties such as headaches, concentration, or at the deeper level, eye movement problems. So this could be due to projections through the frontal lobe of the frontal eye field, which is susceptible to injury. So the study sought to evaluate executive function and eye movement problems in individuals up to 3 years post-concussion. So we recruited from Peterborough and surrounding area, primarily Trent University athletes, and we recruited healthy controls, which were individuals who were free of any lower limb or bone muscle injury and free of concussion in the last 3 years. Our injury control group, they help control for pain and suffering of having to leave daily activities of normal living. And they had not sustained a concussion in the last 3 years, but had sustained a lower limb injury, either to the muscle or bone. And then our injury group, as in the concussion group, they had sustained a concussion in the last 3 years. For our executive functioning measures, we use the SCAT-5 symptom severity scale, Affect Depression Inventory Questionnaire, and then digit symbol, verbal fluency, and coding and trail making. To measure eye movement performance, we used an anti-C.E.T.S task on a 48 trial that required the participants to inhibit action towards the target. For smooth pursuit, we used 2 different speeds, a fast and slow, to measure their tracking ability. And then on a multiple object tracking task, we had the participants track 1 to 5 of 10 moving objects on 25 trials. So our primary findings are as followed. The neuropsych results indicated that the concussion group actually were still reporting severely high symptoms up to 3 years post-concussion. And in addition, our verbal fluency was the only one that was sensitive for the neuropsych measures. Overall, the executive functioning battery wasn't sensitive for concussions against our injury control and our healthy control group. And then moving down to the test of eye movement performance, the percentages of 2 eye movement performance distinguish our concussion group from our injury and our healthy control groups, as well as the tracking lag time on the smooth pursuit task, in that our concussed group was slower at tracking. However, our injury control group was slower than our concussed group. Overall, these findings emphasize that participants are still reporting severe symptoms up to 3 years post-concussion, and it indicates a need to further evaluate eye movement performance and symptom severity following the typical recovery period. Thank you.
Great, thank you so much. And our next speaker is virtual, Rasia Salahandish from York University, who's going to present on nanoporous carbon immunosensor for highly accurate and sensitive clinical detection of glial fibrillary acidic protein in traumatic brain injury, stroke, and spinal cord injury. She will appear soon.
Okay.
Great.
Yeah. Hello, everyone. You have started a great day. I'm Razia Salandish, currently an assistant professor at York University. Although several biosensors reported detected blood or other bodily fluid-based biomarkers of different diseases and injuries, the clinical validation study and thorough comparison are mostly missing. It may be due to the performance of the biosensors that may not permit extensive clinical validation. To overcome this challenge, we created a nanoporous carbon in a novel way and adopted it into a biosensor. Nanoporosity increased the surface area, thereby the number of targets detected on the sensor. Thus, the biosensor provided a wide linear range, high sensitivity, and detection leading to tens of GFAP molecules. To demonstrate the biosensor's clinical utility, we characterized and calibrated GFAP in PBS and serum obtained from human blood. After thorough characterization of the biosensor, 107 clinical samples were measured for detecting GFAP. Out of these, 44 were clinical controls, 26 from TBI patients, 26 from cerebral stroke patients, and 11 from STI patients. A blind validation test performed on all the clinical samples with single molecule array assay, which is called CMO, showed a comparable result, thereby confirming the biosensor's successful clinical performance. Furthermore, statistical comparisons such as passing Babb-like regression analysis, bland and Altman analysis, and receiver operation characteristic curve between the biosensor and the CMO showed that the biosensor was more accurate than the commercially available assay. Overall, we report a faster, reliable, highly selective, and ubiquitous biosensor fabrication and clinical implementation protocol, offering new insights for diagnosing and monitoring TBI, stroke, and SCI. Such a comprehensive work involving a biosensor and clinical measurements for each injury condition led all three together. This report provides a significant stride in creating field-ready devices to bridge the diagnostic gap, especially in neurological injuries and disorders. Thank you very much for your attention.
Thank you very much. And our next speaker is in person, Eden Dales, who's going to talk about females and the injured brain, new information, new interventions.
Let's just try to. Hi, everybody. Nice to be here. Oh, is this? So 3 minutes. So I'm here to talk about the impact of concussions on females. And this is not to say that males don't suffer as much, they do, but this is specifically about awareness and education that females suffer differently and for longer following concussions. This is based on the research that was done many years ago by Sandra Whittleson in Hamilton, who studied Einstein's brain, and she discovered that the female and male brains are different. There's 11% more nerve endings in the brain in females. They're far more sensitive, and she also discovered that the gay brain and the straight brain are different. The left hand and the right-handed brain are different. So we've known this for a very long time. And when you think about the testing that goes on for medications, they very rarely test on female rats because they are variable. So if you think about how little is known about the impact of treatment for many conditions on females and the impact of concussion and brain injury on females, we're just starting to learn now that females really do suffer very differently for longer and more complex symptoms. Females have different brain size and brain structure, different neck movement. They're excluded from drug trials. They have hormonal changes, which makes them variable. They're more sensitive to stimuli post-concussion. They take longer to recover from concussion ABI. Without concussion, females are 2 times higher risk for depression. They have more headaches post-concussion. Females suffer chronic pain and for longer. Females engage in more self-doubt, and the more that they talk about their symptoms and are dismissed as dramatic, they doubt themselves, and they eventually have the same message coming in that they're too much. So this is why we have to believe people when they say that they're suffering, especially when females tell us their symptoms, we have to believe them. There's an impact on the reproductive cycle because the pituitary gland is often impacted, so their periods can change and it can have lasting effects on reproduction. And higher risk for domestic violence, which places them at risk for executive function problems with decision-making after concussion. Then they go back to an abusive relationship and they're hit again. They have a secondary concussion. So it's a repeated cycle, and they don't have the confidence or they might not have the confidence or the skills to make the decision to get to safety. They have harsher post-concussive symptoms, which last longer, earlier onset of anxiety in females. They suffer more headaches than males without concussion. They worry more about their symptoms, and then the symptoms are exacerbated by their worry, and the self-doubt causes the worry to increase, and they feel very much alone in this, and they scream from the rooftops until they're believed. They have poor working memory after concussion, and they can experience abnormal menstrual cycles. So this is a quote from Catherine Snedeker, who will speak this afternoon on founder of Pink Concussions, that women suffer more symptoms than males. And I just want you to think, I'm sure I'm very much done, but I just want you to think about the different life stages over the lifespan, how concussions can impact all the areas of functioning, physical, cognitive, social, and emotional. This is another presentation, but these are some of the examples that you can keep on hand so you can think about when you're working with families and females, you can think about the impact at any given life stage on the 4 areas of functioning: physical, emotional, social, and cognitive. That's the end of what I'll talk about today, but there's slides in here for you that you can view on your own. Thank you.
And I forgot to mention this, but all the posters are online, so you can go through it all in with much more time. So our last presenter is also virtual, Min Hong Kim, who's from Gyeongsuan International School, South Korea, who's going to talk about a novel soccer headgear design to reduce concussion risk in head-to-head collisions.
Thank you. Can you all see my screen?
Yes.
Yes, I'll be presenting a project titled A Novel Soccer Headgear Design to reduce concussion risk in head-to-head collisions. And so some research background to start off. Soccer players can wear headgear that absorb energy during head-to-head collisions, which is outlined in FIFA's laws of the game. While studies are mixed, some studies do show, like the 2 I cite, that wearing headgear may reduce concussion risk specifically for soccer players. And previous studies have explored soccer headgear designs that consist of 1 layer of energy-absorbing polymeric forms. And so our project aim was to propose a novel headgear design that integrates an inner layer of expanded polystyrene and an outer layer of expanded polypropylene foam. And this 2-layer design was hypothesized to optimize energy absorption by integrating the material properties of both foams. And we evaluated this design through finite element analysis. And so in terms of the methods, the 2-layer E.P.S. EPP headband was modeled via a C.E.T platform with an inner layer 7 millimeters wide and an outer layer 8 millimeters wide, and obviously contoured to a human skull. We include properties such as density, Young's modulus, and Poisson's ratio, which are all further detailed in the poster. And so the skull was simulated, fitted with the handband, was simulated to collide with a second skull at a velocity of 4 meters per second at an angle of elevation of plus 30 degrees. This was obtained from a previous study and represented a realistic head-to-head collision of 2 players during an aerial duel for the soccer ball. Finite element analysis of this collision was conducted via SimScale with a mesh of 160K cells and 35K nodes. So this is all simulation theoretical based project. And so in terms of the results, we analyzed peak linear acceleration as well as peak von Mises stress because they're strong predictors of concussion. And I'm not sure where you guys see this, but peak linear acceleration values and peak von Mises stress values have been shown on the slide. And specifically, peak linear acceleration was utilized to calculate concussion risk based on a concussion threshold curve, which comes from a study 2015 by Fernandez. And this 2-layer headgear's peak linear acceleration translated to a concussion risk of below 25%, which was lower relative to 2 other headgear designs that were tested that were single layer based. And to conclude, the E.P.S. EPP double-layer headgear was superior at absorbing energy and reducing concussion risk compared to the 2 other single-layer designs in a simulation setting. And so with further research, similar 2-layer headband designs have the potential to be used in soccer. Thank you.